So what are the goals of long-term outpatient management in patients with a Fontan circulation? I think a lot of this was already covered in the talk by Professor Sellermeyer. Really, the goals in a child are the same as the goals in adult care. What we want to do, or what we want to assess, is whether there's any complications that can develop in a patient with a Fontan circulation. So we know that the majority of patients are doing well and remain well, but as Professor Sellermeyer said, we want to detect changes that are more amenable to a successful outcome if they're detected early. And that might be ventricular dysfunction or heart muscle weakness, valve regurgitation or leaking heart valve, arrhythmia, which is the abnormal heartbeat, thrombosis or clot within the circulation, progressive cyanosis or reduced oxygen level, which may be due to a number of factors, rarer problems such as protein loss from the gut, causing fluid retention, which was talked about by Professor Winlaw, plastic bronchitis, which is where that lymph fluid seems to leak into the tissues of the lungs, and then liver and kidney abnormalities, which A.J. Iyengar will talk about later this afternoon. So we also want to evaluate the ongoing need for and compliance to medications, and they include blood thinners and medications for heart function. But equally importantly, the outpatient care should be a resource for provision of specific health information. And that might be around things such as physical activity and sport, the need for antibiotics around the time of other surgery or dental work, resource for information for the types of employment that could be undertaken, or any other specific adjustments that are required for employment, and contraception, pregnancy and family planning advice. And importantly, we need to ensure that there's effective transition of patients from pediatric to adult services, and also ensure that patients and families are central parts of the treatment team. So this is a quote from me, but just emphasizing, I think, what Professor Sellermeyer said this morning. There is no doubt that long-term outpatient management of patients with a Fontan circulation should be provided by specialist congenital heart disease units. And I thought this quote was quite good when I initially wrote it, but a little bit boring. And I found driving to the hospital this morning, a sign on one of those notices outside a church on Victoria Street, which sort of summarised my sentiment more pithily, which was, wherever you go, go with all your heart. And that was attributed to Confucius, which I thought was quite a pluralistic or tolerant thing to have on a board. But it sort of summarises that you should go to your outpatient appointment, whether it be in the pediatric hospital or in the adult congenital unit, confident that you are receiving good care, well informed about your condition and the treatment for your condition, and also actively engaged in the process of looking after yourself. And I think the characteristics of outpatient care will vary between centres. But more or less, you will see a cardiologist who is a specialist in the care of patients with congenital heart disease, There may be clinical nurse specialists or practitioners who similarly specialise in the care of your heart condition. You'll have access to specialised investigations if they're required, and Professor Sellermeyer outlines some of what we look for with these tests, and they include ultrasounds of the heart, ECGs to monitor electrical activity, MRIs to obtain more detailed pictures of heart function and the structure of the heart and blood vessels, tests of your exercise performance to gauge your capacity now and also to provide some reference for the future, and perhaps cardiac catheter tests to investigate cyanosis or closed fenestrations or closed abnormal veins or that open up and cause reduced oxygen levels. There's access to surgeons and proceduralists if they're required, and also access to other health professionals, psychologists, physiotherapists, social workers. And a key feature of the outpatient facility should be a close link between the paediatric and adult congenital centres. So there are some outstanding questions on the long-term outpatient management of patients with a Fontan circulation. How often should we see patients? And that's an important question, particularly when people feel well. We don't want to ask people to come back more often than they need to, but more importantly, we don't want people to not come back and see us. We're still trying to work out what tests to do and how often, what medications to use and when, what exercise to recommend, what is the timing of transition of patients from the paediatric to the adult congenital heart disease services, how to best look after females with a Fontan circulation through pregnancy, when to recommend Fontan closure and when to recommend Fontan conversion and transplantation. Again, a lot of these things will be discussed later in the day. So I come back to the survey that we conducted, just to give you a gauge of what the outpatient might look like, what the outpatient experience might look like. So we surveyed cardiologists through Australia and New Zealand to get a gauge of what they do with patients with a Fontan circulation. We got a 50% overall response rate of 39 cardiologists. Just under 2/3 were in paediatric practice, and a fifth were in predominantly adult congenital heart disease practice, and a smaller number saw both children and adults. 39% had less than 10 years of practice as a consultant cardiologist, and just under 2/3 more than 10 years. The timing of transition, these respondents said, began mostly between 16 and 18 years, but also between 14 and 16 years was another common response. We tried to ascertain what would be classed as a standard risk Fontan patient versus a high risk Fontan patient. And that's not easy to define. Even in the survey responses, it wasn't very easy to gauge that. But I think it would be important to individualise risk, and that might be based on the type of Fontan, the presence or absence of fenestration, the age since Fontan completion, and current heart function or valve function. So we asked how often should patients be followed up, and mostly patients should be, the recommendation was yearly to 2 yearly, high-risk patients more often. We also asked cardiologists what investigations they do and how often, and obviously higher risk patients tended to get investigations more frequently, but a typical pathway would be a yearly measure of your oxygen saturation, a yearly echocardiogram, an ECG every 1 to 2 years, a Holter monitor, which is a 24-hour ECG only when symptoms are dictated. An exercise test, again, that varied the response to that, but predominantly it was when you had symptoms to suggest a problem. An MRI when you had symptoms, or 3 years, there was a variation in the responses to that. And blood tests to look for your liver, kidney function, and your hemoglobin, which is the thing in the blood that carries around oxygen, every 1 to 3 years, and a cardiac catheter only when you seem to have a problem that needed that test. So with regard to closure of a fenestration, you'll recall that a fenestration is a planned part of some Fontan completions where a small communication is created between the Fontan pathway and the heart, the atrium, and that's to reduce the venous pressure. The positives of that and the negatives were discussed by Professor Winlaw earlier. There is an issue about when should Fontan fenestrations be closed, and so we asked cardiologists when they would do that, and mostly they said they would do that in the presence of reduced exercise capacity or if a patient had a stroke. Some respondents said that they would routinely close Fontan fenestrations. In terms of prescription of physical activity, it was interesting that most cardiologists would recommend at least medium-level physical activity, and some, in fact, said they wouldn't place any restrictions on exercise for Fontan patients. Just under 20% did indicate that they would probably not encourage moderate or high-level physical activity, but some physical activity nonetheless. In terms of pregnancy advice for standard risk Fontan patients, the majority indicated that they felt patients could appropriately undergo pregnancy with appropriate medical supervision. Just under 20% did indicate that they would counsel against pregnancy, however. In regard to contraception advice, most consensus guidelines now would recommend against an estrogen-containing contraceptive and would recommend a progesterone-containing contraception. In female non-smoking Fontan patients, so smoking is a strong risk factor for thrombosis, so very much counsel against smoking. But 20% of respondents recommended using a combined oral contraceptive pill, which would contain estrogen. 40% recommended some form of progesterone-only contraception, and a significant number were unsure about which contraception to recommend. And I think that this result highlights the importance of training and exposure for cardiologists, because the majority of those who felt uncomfortable or uncertain were pediatric cardiologists whose training would be less exposed to issues of contraception and pregnancy. In regard to smoking Fontan patients, a greater proportion recommended against the use of the oral contraceptive pill. So the principles of long-term care in Fontan patients are that care should be coordinated by a centre specialising in congenital heart disease. There will be specific aspects of care that will vary depending on the type of Fontan circulation, the underlying residual problems, physician preferences, and patient and family preferences. There is a goal or an ambition of the Fontan Registry to more standardise care across our region. That is not only to improve the care of patients with a Fontan circulation, but also to minimise potentially unnecessary testing in order to reduce overall healthcare costs. And also importantly, to allow development of a body of evidence for future management by standardizing care and analyzing the outcomes of this care pathway. So thank you very much.
Questions? Anyone? Up the back?
Well, I didn't. I mean, I would advise against it. Yes. I mean that in the Fontan circulation, particularly. So estrogen is known to promote thrombosis or clotting, and I think in most centres and most consensus guidelines would recommend against using it in patients with a Fontan circulation.
Yep, over here. I'm wondering, if you don't have access to an ACHD service where you live, do we know if there's a difference in the outcome for those patients? I have to be honest, I haven't looked at those results in the medical literature recently. My feeling is that, yes, there is indication that the outcomes aren't as good. But I'd be happy to hear from others who may have more information about that. I was asking Eves, if you don't have access to an ACHD service, is there a difference in outcomes?
I think actually, when we look, I thought when we started the registry that there would be a lot of patients who would be followed by adult cardiologists, not having any specialty in congenital heart disease, or GPs, and I found out that for Fontan, so it's different for the rest of people who with congenital heart disease, but for Fontan actually that was not the case so much. So the people either were not going to any doctors or they were going to the right doctors. Majority of the cases, yeah.